Sawasdee krab. Good morning, everybody. It is my great honor to see all of you here. First, thank you very much for inviting me to be a speaker in this special seminar. So today, I would like to talk about the current situations of the pharmacogenomics and precision medicine in clinical practices when the genomics technology drives healthcare system in Thailand. So out of my talk today, it can be searched and read through this review article which published recently. So I would like to take this opportunity to acknowledge all of my grants and my collaborator for supporting me in the pharmacogenomic research. And some of the finding could be delivered to be the national policy for our Thai patients and incorporate into the clinical practices right now. So by overall, I'm going to talk briefly the Genomics Thailand Project. And I would like to update you the pharmacogenomic research and also the potentially pharmacogenetic testing in the clinical practices. Lastly, I would like to deliver what should be considered for incorporations of the pharmacogenetics into the clinical setting. And finally, my experience in research and clinical practices as a pharmacogeneticist will be sharing to you as a lesson learned today. So, as you may have heard that in Thailand, we have launched the Metab project by the government as a Genomics Thailand project. In this project, we would like to establish the whole genome sequencing database from 50K sample of Thai people, which can be recruited by 5 areas. For example, cancer patients, and also the patients with rare diseases and pregnancy women, and non-communicable diseases patients or NCD patients, and the patients with infectious diseases. And lastly, the patient with bad experience from adverse drug reaction for pharmacogenomic study. So finally, we aim to use the genomics technology to drive our healthcare system in Thai people to take care of our Thai patients in a very near future. So let me focus on the pharmacogenomics of Thailand. It can be identified into many areas as shown you in the figure on the left-hand side. So eventually, we aim to transfer our knowledge from research into the clinical implementation for 2 approaches. So the first one, we would like to use the pharmacogenomics as a tool for drug dose adjustment. And the second one is to discover the biomarker for prevention of severe cutaneous adverse drug reactions or SCAR for all Thai people. So we hope that we can prevent our patients from adverse drug reactions and maximize the efficacy to save the budget from public health economic system eventually. So shall we start from the first approach, the pharmacogenomics for prevention of the SCAR? So in the past, SCAR has been identified as ADRB, which is idiosyncratic. So we don't know the cause of the severe cutaneous adverse drug reactions. Therefore, it is unpredictable and it is dose independent for definitions. However, nowadays, we already identified the cause of the SCAR, and we know that the patient genetic is a predisposition factor for this adverse drug reactions. So we can prevent our patients by the genotyping of the biomarkers and stratify the patients as a high-risk group for the patients who are positive of the biomarker. In these patients, they should be avoided for drugs that have a high risk for them. On the other hand, the drug can be used for patients who are negative of the genotyping biomarkers. In this slide, I show you the 2 pharmacogenetic biomarkers to prevent the severe cutaneous adverse drug reaction from carbamazepine and allopurinol for Thai patients, such as HLA-B1502 for carbamazepine and HLA-B5801 for allopurinol. So here, this is picture show the track how to push our research finding into the clinical implementations as a national policy. So you may see that we spent for a long time, nearly 10 years from the first discovery until we get the announcement from the National Health Security Office or SPSH for screening in all Thai people. So step by step. So starting from the retrospective study to discovery, validate and confirm the association in the Thai people, then move into the next step for economic evaluations analysis. And then we perform the prospective screening as a pilot project. At the same time, develop the local or international guideline or information and knowledge from here will be packaged and submitted to the healthcare policymaker to make the considerations for the national policy screening test. So actually, Thailand is not the first country where the pharmacogenetic testing can be provided as a national policy, because in Singapore, they implemented national policy screening before us, maybe 2 or 3 years ago. However, so Thailand, we are just only one country that the patient can get the test without payment at all. So, as I mentioned in previously slide, the HLA-B1502 is the first biomarker that has been approved and announcement in 2018 to prevent the Stevens-Johnson syndrome and toxic epidermolysis from carbamazepine in any indications. Interestingly, the biomarker for carbamazepine has an effect specificity characteristics. So therefore, the HLA-B1301 have to be considered for some population such as Caucasians, Japanese, and also Koreans, as recommended by the US FDA. Moreover, in some populations, the HLA-B serotype 75, such as HLA-B1521, have to be concerned for the clinical implementation too. So by this case report from Thai patients, so we demonstrate that the biomarker for carbamazepine screening is not just only for HLA-B1502, since this case has genotype was negative for the HLA-B1502, and he received the carbamazepine at that time. So after that, he came back to the hospital with carbamazepine-induced Stevens-Johnson syndromes. So what happened in these patients? So when we did the HLA-B genotyping for him, so we found that he definitely negative for the HLA-B1502. However, for the HLA-B genotyping, we found that he carried HLA-B1521, which is the same family of HLA-B1502. It is a HLA-B serotype 75. So we also demonstrate by in the silico model that HLA-B serotype 75 members such as HLA-B1502, HLA-B1508, HLA-B1511, and also HLA-B1521 can present the carbamazepine molecule as you see in the figure. That is a red molecules. This HLA-B genotype can present the molecule of the carbamazepine into the T cell receptor to activate the immune system or immune reactions to present the severe cutaneous adverse drug reaction in these patients. And these associations were found and confirmed in other Asian populations such as Indonesians, Philippines, and also in Japanese study. So therefore, right now in Thailand, we provide the variety testing for screening of high-risk patients. So the test can be delivered at different information level to our physicians for making the decision for their own patients. So first, on the left-hand side, you may see the specific biomarker screening test as they would like to treat of carbamazepine. So therefore, the physician may order a specific HLA-B1502 positive or negative. However, so we have another choice for the physicians as a second one. This is a test for HLA-B genotyping, which can be ruled out the carrier of HLA-B serotype 75 for the patients. And lastly, we also provide the panels of HLA-A and HLA-B genotype as the US FDA recommendations to serve for some mixed children and also Caucasians and Japanese are also Koreans in our Thailand. So recently in these years, the HLA-B5801 is also incorporated into the national policy screening test in patients who are going to receive the allopurinol in Thailand. The patients who are positive for HLA-B5801 will be treated with febuxostat. Right now, the febuxostat can be an alternative choice for the patients because it's incorporated into the national dark list of Thailand. And however, the patient can treat it with febuxostat in the conditioning use category. So therefore, the HLA-B5801 is one of the conditions that the physician can choose febuxostat as an alternative choice for that patient. So we also demonstrate in Thai study that not just only for the genetic predisposition factor, but also the non-genetic factor such as allopurinol dose and also the renal impairment status can also be a predisposition factor for allopurinol-induced scar. So therefore, in 2020, the American Rheumatology Guideline has recommended to start the allopurinol with lower dose, which is less than 100 milligrams a day, especially in the renal impairment patients like chronic kidney disease patients. So last year, not just only for HLA-B1502 for carbamazepine and HLA-B5801 for allopurinos, but in our group, we also first discovered the biomarker for cotamoxazole induced stress. So we found that the HLA-B1301 showed a strong association for cotamoxazole induced stress. However, we also confirmed the associations between HLA-B1502 for cotamoxazole induced Stevens-Johnson syndrome and 10. So you may see that this is the first time to demonstrate that the biomarker for cotamoxazole has phenotype specificity because the HLA-B1301 is specific for cotamoxazole induced stress, whereas HLA-B1502 shows association with cotamoxazole induced Stevens and 10 only. Moreover, our finding has been confirmed by the other study that we collaborate with Taiwan groups. So in this study, the HLA-B1301 has been confirmed the associations by whole genome sequencing in more sample size and various population of Asians, such as Han Chinese in Taiwan, Thai patients, and also Malaysian patients. In this study, we also demonstrate in the in silico model that not just only for sulfamethoxazole, but also its metabolites like sulfamethoxazole nitrosole can be a trigger of immune system to initiate the scar from cotamoxazole in the patients. So in this reaction by the in silico models, we also confirm and demonstrate by the in vitro study that we have been done in Liverpool University lab under supervision of Professor Dean and Professor Munir in Liverpool University. Interestingly and surprisingly, the HLA-B1301, which show the association with cotamoxazole, is also show the association with that zone in Asian populations. So in this study, we found the associations of HLA-B1301 for dapsone-induced scars, severe cutaneous fluctuations, and also it can be confirmed by the other populations such as Chinese and also in Indonesians. Interestingly, we first characterized the phenotype non-specificity for HLA-B1301 in dapsone because so you may see that the HLA-B1301 show associations not just only for DRESS, but it also show the association with Stevens-Johnson syndrome and 10 in Thai populations. So we also recently also confirmed in the more sample size and also demonstrate that on the right hand side, you may see in the figures that we try to demonstrate in the in silico model that not just only for dapsone, but its metabolite like dapsone, nitrosole can form the bond or can be the trigger to reactivate the immune system of the patients to present the T cell receptor and trigger the immune system in the patients who got that zone induced scars. So one of the key factors for the implementation as a national screening test is the frequency of the allele risk and real in the populations, and it can be influenced to the economic evaluations to convince the healthcare policymaker in the Thai populations. So as I shown in this figure, we show that. So in Thai populations, we are very high frequency of the risk and real in Thai population. For example, we have 16% of Thai people who carriers of the HLA-B 1502 for carbamazepine. And we found that in Thai patients, we have 15% for HLA-B 5801 for alloprenose, and also 13% for dapsone and also protamoxazole in Thai patients. And so for the high frequency, it's not just only for Thai people, but it's also shown in the Southeast Asian community as well. So here, so I have updated and summarized the pharmacogenetics biomarker to prevent the scar from Thai study. So you may see that, as you may know that the HLA-B 1502 has been announced to be the national policy screening before carbamazepine treatment. So it can be applied for the selecting of carbamazepines as well, because oxcarbamazepine share the risk marker allele for HLA-B 1502 as same as for carbamazepine. Since it's look very similar in the structure of oxcarbamazepine and also carbamazepines. And not just only for that. So in this year, the HLA-B 5801 has been launched as a national policy screening in our Thai patients as well. And as I mentioned that last year, we already discovered the biomarker for protamoxazole and dapsone, and we try to push our effort to propose this biomarker for the screening in our Thai populations by starting off the cost effectiveness analysis first. So as you may see by the tables here, that almost of the biomarker for drug-induced scar has been located on the HLA-B genes. Therefore, it allows us to deliver a panels for interpretations and make the report as a panel predictions in the clinical implementations. As you may see in the figures in these patients carry HLA-B 0702 and 0801, which is not matched to any biomarker for drug-induced scar. So therefore, they can use the drug as safely for these drugs. So the HLA-B gene is in the germline genes. Therefore, there are no change at the whole life of the patients. So therefore, in the individual, they can genotype once in a lifetime. And from this concept, their data of the genotyping can be remained into the electronic medical record and update for the whole life for individuals to save them for a future drug as well. So in this case report, I would like to emphasize you how important of the electronic medical record and also the counseling system and also the awareness of the health professionals in the country. So the electronic medical record is very important for the clinical implementation for pharmacogenetic testing. In this case, so I would like to share you our bad experience, and you may learn from our missings until we lost our Thai patients, even we have the national screening test. Because when we test the HLA-B 1502 for these patients, and we found that she was a positive for HLA-B 1502 during she was admitted in the IPD ward until she get better and recovery from her diseases, epilepsy, and she was discharged from the hospital and go back to her hometown, and she asked to come back to the hospital 1 month later. However, she came back to the hospital to see the doctor, but she she cannot see the same doctor that did the genotyping for her, but she see the different doctor, the other doctor that have no awareness for a pharmacogenetic testing, and the doctor found that she might not be control her epilepsy wells by phenytoin, by the drug only. So therefore, the doctor prescribed carbamazepine on top of that drugs at that time. So therefore, she came back to her hometown with carbamazepine. So unfortunately, she got toxic epidermal necrolysis, and she died from carbamazepine-induced toxic epidermal necrolysis. So when we explore in this event, we found that we lost all the key success for clinical implementation. One is a health professional awareness, and we have no electronic medical record at that time for the pharmacogenetic informations, and we have no the counseling system for the implementation. So therefore, the electronic medical record has been enhanced to set up to alert the doctor when they order a high-risk drug such as abacavir, carbamazepine, and also allopurinol. Even they have no awareness or have no knowledge for the pharmacogenetic screening test. But when they order the drugs that have a high risk, the alert system will be popped up for them to order the pharmacogenetic testing. And when the genotype has been done, the result will be incorporated into the electronic medical record to warning them or pop up them if the patient has a positive result. The physicians and also pharmacists should be avoided for prescriptions of the high risk in that patients as shown you in the figures. So this is a 10 years data from my lab. So you may see that the number of the requests of the pharmacogenetic screening for carbamazepine, allopurinol, and also abacavir has been increased year by year during 10 years. And on the other hand, you may see on the panels below that the incidence of the Stevens-Johnson syndrome and toxic epidermal necrolysis from the pharmacovigilance report, you may see that the case has been decreased year by year as well. So not just only for a pharmacogenetic of screening approach, but the pharmacogenetics in the clinical practices. Pharmacogenetic approach can be applied to minimize the toxicity and maximize the efficacy in the patients by drug dose adjustment. So in this approach, we usually do the genotyping of drug metabolizing enzymes and then translate to be the predicted phenotype according to the international guideline and also the consensus algorithms like CP guideline and also PharmWar. And by theory, the normal metabolizer on NM has been assigned to be to the patients who are wild type of the genotyping for both alleles. And so you may see that by the pharmacokinetics profile of the normal metabolizer, they should be within the therapeutic levels. On the other hand, so the patients who are ultra rapid metabolizer or have been assigned for the patients who carry an increased functional variance for the both alleles. In these patients, they have to increase drug dose adjustment to reach the efficacy level, since the drug should be subtherapeutic level like the profile in the figures. And on the other hand, the patients who are poor metabolizer or PM have been assigned for non-functional variants for both alleles. In these patients, this patient may need to decrease dose to prevent the toxicity, as a very high plasma drug concentration has been found in the figures. Interestingly, in the patients who are heterozygous for non-functional variants, they should be assigned to be intermediate metabolizer or IM. So in these patients, the dose may not no need to adjust uh, by the pharmacogeneticists. Because, however, there should be concern or be careful for the drug interactions or herbs interactions, especially drug inhibitor for the patients, because the patients might, the drug level of the intermediate metabolizer patients, like you may see in the figure like B, may shift up to be a SMF for poor metabolizer if they treated with drug inhibitors. So in this table, I also summarize here the very important pharmacogenes and also the genetic variant for clinical relevance from Thai study. In these genes and variant have shown the effect for the efficacy and toxicity for these drugs, such as CYP2C19 for clopidogrel and voriconazole, UGT1A1 for irinotecan, and TPMT and also NUDT15 for 6-MP and azathioprine in Thai patients. And in these years, we have discovered the novel variant which no function for CYP2D6 as shown you in the tables, like CYP2D6 star 143 that is already registered in the international database like PharmWar. And in this discovery, we can develop the Thai algorithm for translating CYP2D6 predicted phenotypes and also review some mysterious issues in the clinical practices for Thai patients. So I would like to give you a case study. In this boy, he got febrile neutropenia from 6-mercaptopurine for treatment, and his sample referred to Ramatipati Hospital for TPMT and NUDT15 genotyping because for the TPMT and NUDT15 enzyme activity are the enzymes to convert the toxic molecule like 6-TGNs to be the non-toxic substance in the metabolism pathway of 6-MP. And also, after it's converted the 6-TGN to be non-toxicity, TPMT can help to excrete out of the toxic substance out from the patient's body. So by the genotyping in these patients, it can reveal that this boy cannot convert the 6-TGN to be non-toxic substance as he carried the homozygous of non-functional variant of NUDT15. As you may see that he was he is a carrier for STAR3, STAR-T, which is a homozygous of non-functional of NUDT15, and we can predict it as a poor metabolizer in this patient. So this is the answer that why this patient got toxicity, and he has to decrease dose for 6-MP to prevent their life-threatening adverse event for febrile neutropenia in this patient like this. And moreover, here I show you the case study from patients who got the CYP2C19 genotyping after the adverse event by acute coronary stent thrombosis from clopidogrel resistance after they did the OR for stent implantations in these patients. So as you may know that the clopidogrel is an inactive metabolite and it needs CYP2C19 in the patient's body change from the inactive form to the active form, and the patient can get antiplatelet aggregations after CYP2C19 change them from inactive metabolites to be active metabolites. So however, in these patients who got clopidogrel resistance, when we did the genotyping for these patients, we found that he carried the CYP2C19 non-functional variant for both alleles, like STAR2 and STAR3. The predicted phenotype of this patient has been classified as poor metabolizer. Therefore, the CYP2C19 has no function at all in this patient. This is the answer that why he did not get the efficacy from clopidogrel. So you can see if this patient got the screening of CYP2C19 before he got the stent by the physicians, and the doctor can choose appropriately alternative choice like ticagrelor or prasugrel instead of clopidogrel in this patient, and he no need to has an experience for clopidogrel resistance and turn back for the OR for resistance again at that time. So you may see how impact of the CYP2C19 for the clopidogrel resistance in that patient. And so, so you may see that how can we solve these problems? Like now, the electronic medical record should be set up to notice the doctor when they prescribe clopidogrel for a patient, and the doctor will be informed to increase the clopidogrel dose when the patient are intermediate metabolizer. On the other hand, the physician need to choose the alternative choice like ticagrelor or prasugrel when the patients are poor metabolizer. So that is a impact of the single genes and single drugs. However, in the real world, the drug response may affect by many factors, not just only for the genetics variations, such as drug interactions in the polypharmacy regimen. And sometimes the patient may have a complicated condition in their life, like they may get like herbs or like food interactions, and it may interfere the drug response in that patient, like in this case that I show you here. So, and also as the patient got the polypharmacy, like now we implement the panel of the pharmacogenetic testing for a patient who may have like polypharmacy like this. So you may see in this figure, the patients may get like cost effectiveness analysis. So when they genotype for a panels in that times, because they got a lot of polypharmacy that need more genetic information, not just only for the single gene test. And from these panels, so you may see that as we known by the pharmacology that not just only one drug and one metabolism pathway, but for one metabolism pathway, it can be served for many drugs. Like in this figure, you may see that CYP2D6 may play a metabolism pathway for antidepressants, and on the same time, we can use the CYP2D6 genotype for do the dose adjustment for antipsychotics and also opioid analgesics, right? Clopidogrel and tramadol for CYP2D6, and in some patients we can use the CYP2D6 genotyping for tamoxifen in the future of their life. So you may see that this is the impact of how we do the panel pharmacogenetic testing. And as I mentioned that, not just only for the genetics, that is a predisposition factor for drug response, but they might have another factor like diseases, like food and herbs. So therefore, we are using the clinical decision support tool, which can help to integrate all patient information, including genetics and non-genetic factor, into the algorithms, and the drugs recommendation will be listed as a precision medicine approach for at the current regimen and also in the future of treatment. So you may see on the right-hand side of the drug list, the drug with red color have to be avoided in these patients according to the genotyping, while the yellow can be treated with precautions, and the drug in the green table can be prescribed safely for that patients and also in the futures, if we did not concern other factors, but just only for the genotyping. So as the same concept of the germline genes, so we are now move forward to the preemptive pharmacogenomics testing in some setting using the next generation sequencing platform, as the drug metabolizing enzymes and the transporter genes are the germline genes. So the genetic profile of the patient will not be changed in their whole life. The patients can be tested just once in a lifetime, and the genetics profile can be remained into the electronic medical record, and it can be updated for the future treatment, and all the doctors who are going to take care of these patients will be noticed when they provide the prescriptions drug according to this gene profile. So for the clinical implementations, the precision medicine workflow will be multidisciplinary team that should be identified and set up in the hospital. And the doctor will be noticed if they order such a drug that have high risk for scar or the drug that needs dose adjustment. And so after the doctor order the drugs, the clinical pharmacist or the pharmacogeneticist will be alert for pre-counseling and also post-counseling system for the patients. And so for the post-counseling system, the pharmacist or geneticist can be do the counseling for not just only for the patients, but sometimes we need to counseling for the doctor or the physicians as well if they have no idea for the clinical use for a pharmacogenetic testing at that time. By the counseling system, we can set as a personal pharmacogenetic counseling. So we can use this opportunity to deliver the patients for a pharmacogenetic card and also the precision medicine result. And we also let them know that what their own risk and which drug that should be avoided in their future life according to the genetic profile of that patient. And as you may see like now, as you may know that the COVID-19 outbreak and 19 outbreak in Thailand is very bad and it's getting worse situation in Thailand. So therefore, we have to set up the telemedicine or telecounseling for our setting. So in this system, we can counseling remote for our patients who are inconvenient to come to the hospital since they may scare of the COVID-19 exposure when they come to the hospital to see to see the pharmacist or the pharmacogeneticist. And so as we lack of the genetic counseling in our country, and the Genomics Thailand is a national agenda right now, all related public health council in Thailand join together to prepare the human resource and develop the training course for a genetic counselor. But specifically, the Pharmacy Council of Thailand also prepare the training for a pharmacist who will be in charge for a pharmacogenomic in clinical implementations. And as we know that we lack of the health professional awareness, we also provide a workshop, academic meeting, and also conference to provide the knowledge and enhance their awareness throughout for the physician throughout the country. So as here, I summarize you the role of the pharmacist as I try to emphasize you that the pharmacist may play a major role in the pharmacogenetics in the clinical implementation. The pharmacist might be transformed to be the pharmacogeneticist like me in the clinical implementation. So the pharmacist should be able to choose the right drug, choose the right test to the right patient, interpret the genotype to be the predicted phenotype, and recommend the therapeutics by choose the drugs, right drug and right dose to the right patients, and deliver the report to the physician and also the patients by the counseling system as well. And they should be able to do the pharmacogenetic research and translating the finding to solve the clinical problems. And the pharmacist should be deliver the pharmacogenetic knowledge and training for the healthcare provider. So in this year, like now, I think that in Thailand, so pharmacogenomics, we are in the era of the pharmacogenomics-driven healthcare to eradicate and prevent the severe cutaneous adverse drug reaction and also maximize the efficacy of the treatment by dose adjustment in our country. So now I would like to take this opportunity to thank all members in the Pharmacogenomics Network of Thailand to push the effort too much for the research and also the clinical implementation. Internationally, some of you may know that in Southeast Asia, we have the networking for CPharm, and right now, the CPharm has been established for 10 years ago to enable and strengthen the pharmacogenomic research among the various pharmacogenetic community in this region. At the moment, in this year, it has been transformed to be Southeast Asian CPharm Association. And on behalf of the CPharm Associations and the Secretary of the associations, I would like to welcome if you would like to join us for the community in the pharmacogenomic research. And lastly, I would like to say thank you for all of my members in the PPM labs. So in this setting, you may see that we have two pharmacists in our lab, in our setting. So one of the pharmacists is Mr. Nathan. He graduated from a faculty of pharmacy, Chulalongkorn University, and he now trained to be the pharmacogeneticist. And I think that pharmacists have to play a major role and take this opportunity to play our capability for a pharmacist in the pharmacogenomic research and also in the clinical implementation. So on behalf of the Pharmacogenomic of Thailand, so I would like to thank you very much for all of you for attention, for pay attention, and we welcome for the collaborations, and thank you very much for your attention. Thank you.